My name is Stephanie Smith, and I will be presenting to you my evidence-based Pico project. So in December of 2019, a series of pneumonia cases broke out around the world that would later be labeled as coronavirus or COVID-19. COVID-19 was complicated with severe respiratory symptoms that in worst cases led to ARDS in about 20% of hospitalized patients. As healthcare providers, we know that ARDS carries a high mortality rate along with it at about 35 to 46% as reported. Prone therapy was previously used in the management of ARDS patients dating as far back as 1970. However, it wasn't frequently used until the outbreak of COVID-19. In older literature, prone therapy has been proven to have positive effects with oxygenation. And knowing little to nothing when the pandemic first broke out, medical professionals were kind of at their last straws to try anything to help survival rates. So this being said, I wanted to analyze how this prone therapy could be used in the new pandemic. And my Pico question is as stated. In patients infected with the coronavirus, how does implementing pronation versus supine positioning affect outcomes? Once forming and revising my Pico question, I started a literature search. Some of the key terms I searched are as listed on the slide there. I mainly used Cochrane and PubMed as my databases. After critiquing several articles, I chose my final ones for synthesis. They included 5 systematic reviews, 1 randomized control study, 2 cohort studies, and 3 other quantitative studies such as retrospective, prospective, quality improvement studies. So 2 main themes kind of emerged as I was analyzing these articles, and they are mortality and intubation rates. So 3 articles stated that the use of early prone therapy can decrease mortality. The articles further discussed that prone therapy has a significant lower 28-day mortality, and outcomes are improved if prone therapy is done for at least 12 hours. Another thing they examined was the PaFiO2 ratio, which is a calculation many providers use when determining lung function in severe ARDS, including our COVID-19 patients. Researchers found that PaFiO2 ratios were increased in patients who underwent prone therapy, although they couldn't say that this was attributed to mortality another way. It's just something important to consider in the care management of these patients. The second theme was intubation rates. For patients who were not mechanically ventilated, prone positioning has been proven beneficial. Intubation rates were higher in patients who did not undergo prone therapy, and vice versa. Patients who did undergo prone therapy had a decrease in intubation rates. So as far as recommendations, I found that much of the literature out there was either super dated discussing ARDS or very current discussing COVID-19 specifically. So I think there is a big gap in literature and more research needs to be completed, especially since we brought an old therapy back to light and we're using it more frequently. At the same time, though, I do believe that there is enough research to say that we should be using prone positioning as a therapy in managing our COVID-19 patients. And to wrap everything up, Prone positioning has been found successful in improving oxygenation for both mechanically ventilated and non-mechanically ventilated patients, so much so that it's been included in new guidelines and care bundles. And I think that we should implement this in the care management of our patients until proven otherwise.